in the upper right.
When you give a presentation of a patient, you're really breaking it down into 5 components: the subjective, when you give a presentation of a patient,
JD is a 57-year-old African-American male presenting to the clinic today with complaints of an itchy rash to his right foot that he noticed about 2 weeks ago. He is an established patient that is married and accompanied by his wife today. He describes that the rash has gradually become bigger and itchier over the last 2 weeks. The itching is intermittent and comes and goes throughout the day. He describes that the itching is worse at night when he is trying to sleep and lasts for about an hour once it starts. He describes the itching as mild when it starts to itch and has taken Benadryl 25 milligrams by mouth at night, which has relieved the itching overnight. Nothing seems to make the itching worse. The itching does not radiate to other parts of the body and is isolated to his right foot. JD reports that the itching does not interfere with his ability to work or with activities of daily living. He denies decreased mobility or range of motion, denies pain with movement of his feet. He denies excessive moisture, abnormal color or paleness, or cyanosis, and he reports that he has been having trouble sleeping at night for the last 6 months, and he barely sleeps at night. He reports that he watches TV when he is struggling to sleep and that taking trazodone before bedtime is no longer helping. He reports having tried melatonin over the counter, which also did not help. He reports recent vision changes over the last few months that he has seen an ophthalmologist for to get new glasses. He sees an ophthalmologist and gets a yearly eye exam with retinal dilation because of his diabetes. His last eye exam was done in March of 2022. JD has a history of insomnia that started 6 months ago, eczema diagnosed in 2000, hypertension diagnosed in 2015, dyslipidemia diagnosed in 2019, diabetes type 1 diagnosed in 2004. He denies any past surgeries or hospitalizations, denies headaches or muscle aches. He reports a recent weight gain of 15 pounds in the last year, denies sweating, fever, chills, or fatigue, denies ringing in the ears or hearing loss, denies discharge from the eyes, denies runny nose, congestion, or sneezing, denies throat or mouth pain, denies a rash to any other part of the body besides his right foot, and denies sun sensitivity, denies chest pain or palpitations, denies cough, chest pain with inhalation or shortness of breath, denies painful urination or blood in the urine, denies constipation or diarrhea or blood in the stool, denies nausea or vomiting, denies arthritis or pain with movement, denies dizziness, fainting or unconsciousness, seizures or memory loss, denies hot or cold intolerance, polydipsia, polyphagia, or polyuria, denies lymphadenopathy or easy bruising. He denies anxiety or depression, and on his exam, his head is normocephalic without visible bumps, masses, or depressions. His eyes are symmetrical, perla, normal ocular movement in all directions without nystagmus or strabismus. His ears are symmetrically placed, no drainage or cerumen noted. Tympanic membranes, pearly gray and translucent with visible light reflex bilaterally, no signs of hearing loss with whisper test. No deviation to the nasal septum noted, and no bleeding or discharge noted. Turbinates are light pink with no edema bilaterally. Lips and oral mucosa are pink and moist. Tongue is pink and moist, and no unusual lesions or abrasions. Tonsils are +2 with no abnormalities. No swollen or tender lymph nodes on palpation. No rash to the neck, and normal range of motion in the neck. Heart with normal rate and rhythm when checked apically. No murmurs, rubs, or gallops. PMI is noted at the left fifth intercostal space at the midclavicular line. Chest wall symmetrical, respirations with regular rate and rhythm, no signs of labored breathing or use of accessory muscles, no adventitious breath sounds heard. Abdomen non-distended, rounded, and soft, hyperactive bowel sounds heard in all 4 quadrants, no organomegaly, no tenderness on palpation, no masses or swelling noted. No CVA or flank tenderness noted. Erect posture, full range of motion to all extremities. The patient can bend from side to side and forward and backward. No use of assistive devices for ambulation. Awake, alert, and oriented to person, place, and time. Follows commands and answers questions appropriately. Appropriate mood and affect. Labs that were ordered today in the clinic are creatinine, GFR, CMP, AST, ALT, lipid profile, hemoglobin A1C, and TSH. His blood glucose checked in the office today is 213. A physiological intrapersonal stressor that is affecting JD is that he doesn't follow a healthy diabetic diet. He eats mostly fast foods and fried foods, and he doesn't drink water. A psychological intrapersonal stressor that is affecting JD is that he isn't properly managing administration of his medications for diabetes. This is evident because he hasn't been administering his medications correctly and at the correct dose that he was instructed to at the last visit. Physiological interpersonal stressors that are affecting JD are type 1 diabetes that's uncontrolled because he has not taken his medicines as prescribed or following the recommended diet. Developmental interpersonal stressors that are affecting JD is that he shows disinterest with learning when to take his medicines and how to follow the treatment regimen. Spiritual extrapersonal stressors that are affecting JD is that he reports that having diabetes makes him feel distressed, and he reports that the main issue is the cost of his medications and supplies. He reports that his healthcare coverage doesn't cover for enough supplies and insulin each month and that he is running out. A sociocultural interpersonal stressor that is positive is going to church with his wife almost every Sunday, which he states gives him a sense of well-being. And the patient's normal line of defense has been penetrated. This is evident because the patient has symptoms of illness or high blood sugar. He has vision changes, and he also has a tinea pedis infection. His blood sugar is also high because he is not administering his insulin at the right dose and time. This is another sign that the normal line of defense has been penetrated. The flexible line of defense could no longer protect the normal line of defense because of JD's chronic illness and the lack of proper management of the disease. It is evident that the line of resistance was activated because he has a fungal infection, which is a result of his high blood sugar or lowered immunity against fungal infections. And this is taken from Newman and Fawcett, 5th edition, 2011. The differential diagnoses are tinea pedis, contact dermatitis, and eczema. Tinea pedis, which includes positive case data of a scaly, itchy patch of skin. The patient wearing socks, which increases moisture to the feet. Tinea pedis is more common in people with poor health, and JD has uncontrolled diabetes. It's more common in warm climates. The site of the rash is in a high moisture area of the body. And the negative case data for tinea pedis is that there are no signs of fungal infection to the interdigital spaces of the foot, which is the most common area for the infection to start. This diagnosis was taken from Clinical Guidelines in Primary Care, Hollier, 2021. Another differential diagnosis is contact dermatitis. The positive case data is a scaly rash, and the negative case data is that contact dermatitis is more common in occupations of nursing, hairdressing, and house cleaning, and JD works in a grocery store. Also, it can be caused by jewelry, and JD denies wearing jewelry. JD denies being in the woods or a yard recently, and no use of new products like laundry detergent, soaps, or lotions. Also, there is no erythema. This differential diagnosis was taken from Clinical Guidelines in Primary Care, Hollier, 2021. The last differential diagnosis is eczema. The positive case data is that the patient does have a history of eczema and the rash is itching and dry. However, the negative case data is that there is no bleeding or oozing, which can be present with eczema. The rash is not on a part of the body that is commonly affected by eczema, and the patient denies coming into contact with any known allergens that are known to exacerbate his eczema. This information was taken from Family Practice Guidelines, Cash, Glass, and Mullen, 2021. All of this data, along with the history and physical, leads to a definitive diagnosis of tinea pedis. The diagnosis was made based on symptoms and history and physical. Therapeutic interventions are the patient was instructed to use proper hand hygiene prior to applying cream to the tinea pedis infection to prevent a secondary infection. This is primary prevention and also using expert coaching and guidance. The patient was instructed to follow a diabetic diet as ordered to prevent future tinea pedis infections and to promote healing of the current infection. This is primary and tertiary prevention and based on evidence-based practice. JD was also instructed to wear open footwear and to not wear socks while the fungal infection is healing and to prevent future tinea pedis infections. Primary and tertiary prevention, and this is based on evidence-based practice. JD was instructed to follow up with the diabetes educator in 5 weeks for instructions on how to carb count and what diet to follow. This is primary prevention and using consultation. Interventions were taken from Clinical Guidelines in Primary Care, 4th edition, Hollier, 2021. Teaching and counseling was taken from Hollier, 2021. And the teaching and counseling is that JD was instructed to shower daily and clean the affected area with a mild soap. And the patient was not encouraged to avoid occlusive footwear, but according to Clinical Guidelines, this can be effective at reducing fungal infections and helping them to heal. The patient was encouraged to keep the fungal infection as clean and dry as possible. And according to Clinical Guidelines, patients should be encouraged to remove wet clothing as soon as possible and to dry between the toes after showering and bathing. And the patient was not encouraged to follow this recommendation. According to Clinical Guidelines, it is recommended to avoid contact with surfaces in public bathing facilities. And according to Clinical Guidelines, it is recommended to avoid sharing clothing, sports equipment, or towels with other people and to put socks on before undergarments. JD was also encouraged to use clotrimazole betamethasone cream, BID, to the affected area after cleaning it and drying well. Client goals. The patient will have a significant reduction in itching after using clotrimazole betamethasone cream twice a day for 10 to 14 days. And after consistently wearing open footwear and no socks for 14 days, the patient's tinea pedis infection will heal and no new sites of tinea pedis will develop. The patient will reduce factors of developing tinea pedis by compliance with a diabetic diet and taking diabetic medications as ordered. The patient will get better sleep by following treatment for tinea pedis due to decrease in itching to the foot at night. Hypothesis is that if the patient follows the recommendations as stated, then the itching and discomfort caused by the tinea pedis infection will be significantly better in the next week. The follow-up and evaluation plan is to have the patient call the clinic if the tinea pedis infection is not getting better or seems to be getting worse after 1 week of treatment. The patient was instructed that if the tinea pedis infection is not starting to heal after 1 week of treatment, it may be necessary for him to follow up with dermatology. If the infection is getting better with treatment, then the patient does not need to call the office in 1 week. Instead, the patient can follow up in 3 months as discussed. The patient was instructed to have all lab work that was ordered today drawn prior to his 3-month follow-up visit. And at the next appointment, the blood sugars on the continuous glucose monitor and the diet that the patient has been following will be assessed. The tinea pedis infection will be assessed for resolution and whether any new infections have occurred. If it is found at the next appointment that the patient is getting recurrent tinea pedis infections, then referral to dermatology may be considered.
And you'll have to sign in.